This project started in response to an observation that we made at our center. We saw that significantly fewer women than men were seeking treatment at our center, despite evidence showing similar trauma and PTSD rates among both genders. This led us to ask questions like, are women less likely to seek trauma treatment? If so, why is that? Are current treatments unsuitable for their needs? Or are women's trauma experiences being overlooked by the primary health care, who are usually the ones that refer patients to us? So to give you a bit of context, so the RKC Malmö, which is our center, is one of 5 treatment centers or Red Cross treatment centers in Sweden. We treat approximately 400 patients per year, of which 60% are men and 40% are women. We treat PTSD from war, torture, and forced migration. And at our center, we have psychologists working, but also physiotherapists, social workers, a medical doctor, interpreters, and administrative personnel. We all know that conflict, torture, and forced migration affect the health and well-being of millions of women every year. Research shows that women and men experience trauma differently. Women, in general, report fewer traumatic events, but are more often exposed to family-related and sexualized violence. Refugee women face worse health outcomes than do refugee men, including higher rates of pain, poor mobility, lower quality of life, and mental health issues such as anxiety, depression, and PTSD. Despite severe health issues, women often face barriers to accessing healthcare, such as family responsibilities and societal constraints. In Sweden, trauma-focused care is unevenly distributed, with specialized treatment available in only half the regions. Primary care often handles PTSD treatment, though knowledge levels vary. The evidence base for PTSD treatment is on an international level low, but recommendations for treatment include EMDR, various CBT treatments, and body awareness training. There is a huge need for further research regarding PTSD for specifically vulnerable groups such as women, children, or people with complex PTSD. The work that we did in phase number 1 and 2 laid the foundation for the work that we have done in phase number 3. So in the following presentation, we will walk you through each of these phases. So we're just going to show you these. So far in the project, we've published 4 scientific articles and 2 Swedish reports.
So in the first phase, we conducted 2 sub-studies. In the first sub-study, we wanted to summarize and analyze previous research on women's experiences of war, torture, and migration. For sub-study 2, we conducted a scoping review of studies testing and evaluating interventions to promote health for women with experiences of war, torture, and migration. Here we have the results for the first study, the theme and the sub-themes. We found 3 themes, and within each theme, we identified several sub-themes. Some of these themes and sub-themes can be seen as more general experiences that apply for both women and men, but we also identified some sub-themes that we thought were more gender-specific for women. In the first theme, women described war and conflict as events that turned their entire existence upside down. The sub-themes we found revolved around a reduced sense of safety, difficulties in meeting basic needs, the process and decisions leading to migration, as well as the aspects of traumatic experiences that could lead to positive consequences, such as growing closer to family members as a result of what they had endured together. The second theme concerned the health-related consequences of war and migration. These included stress and mental health issues resulting from the challenges the women faced, as well as difficulties in accessing healthcare and support during war and displacement. We also identified recurring sub-themes that were more specific to women, namely the particular vulnerabilities associated with being pregnant or giving birth in our war and migration context. And another prominent and recurring theme was women's multiple exposure to violence. And the third theme we identified concerns women's resources and strategies to cope with the difficulties they faced. Because despite the numerous challenges that women encounter during war and displacement, they managed to mobilize and utilize resources to care for themselves and their families. In study 2, we wanted to examine the interventions that women were offered. So in the 13 articles that we included, we identified 10 different interventions. None of the interventions offered traditional trauma therapy. Instead, they showed a variety of approaches in terms of content. These included creative measures, such as using puppet theater to discuss how displacement had affected women's roles in the family and society, interventions where women learned entrepreneurship, interventions for processing grief over lost spouses, and interventions for coping with life as it was at the time. And all interventions, except for one, were group-based, and the interventions were primarily delivered by facilitators or peer supporters, most of whom were women.
When having analyzed the research data, the results showed that the women showed both poor physical and mental health, and they lived in challenging psychosocial circumstances. They were also carrying high levels of responsibility for their families and home, and at the same time they were struggling to establish themselves in Sweden. However, they also showed a lot of strength and resilience in trying to cope with the challenges that they met. They were also survivors of gender-based violence, something that was described to occur on both individual and structural levels, persisting from their home countries into their new environments in Sweden. According to feedback from the focus groups and the women, the reception at the Red Cross Treatment Center was positive. While the women reported experiencing positive health effects of the treatment, both healthcare staff and women also said that it was challenging. We also asked them about barriers for treatment, and several barriers were identified on different levels. Individual barriers to treatment for the women included issues of trust and fear of male healthcare personnel. They also saw and identified psychosocial barriers included women responsibilities for family and children and their home, concerns about finances, and uncertainty surrounding asylum processes, for example. On a structural level, the need for increased knowledge about refugee women was highlighted. Improvement suggestions were provided by both the women and the healthcare staff and included, for example, improving collaboration with other healthcare services and authorities, and enhancing the knowledge on how to address ongoing violence during trauma treatment. These apply to both clinical practice and further research. Clinically, there's a need to increase access to interdisciplinary treatment. We need to raise awareness of what available support there is and promote collaboration between healthcare institutions and authorities. Efforts should focus on overcoming gender-specific barriers to care, for example, by offering digital treatment options and also providing support groups for women on rights, parenting, and peer support. Also, care planning should emphasize women's strengths. Future research should continue to explore gender-specific and culturally sensitive aspects of healthcare for refugee women, focusing on effective components in trauma treatment, long-term outcomes, and the role of peer support. Women should also be actively involved in research regarding them and development efforts.
So, since the women at the Red Cross Treatment Center in Malmö already are offered individual trauma treatment, we decided that the intervention would not focus on treating PTSD. Instead, we wanted to develop a complementary intervention that could be offered alongside the trauma treatment or as a standalone option. And we wanted to focus on three things. We wanted to take like an overall aspect on the women's health. So we wanted it to consist of psychological treatment components, physiotherapeutic treatment components, and psychosocial treatment components. And we also wanted to offer the women the possibility to be in a group according to our findings on the importance of social support. So we hoped that the group format would provide the women an opportunity to offer each other social and emotional support and to establish new contacts, which could reduce the feelings of loneliness and social isolation. We define the intervention's purpose as follows: to create conditions for post-traumatic growth and the exchange of social support by sharing experiences in a group setting of being a woman during war and displacement and how these experiences impact life today. So we hoped for the intervention to help the women break the culture of silence and reduce feelings of shame and enhance their feeling of empowerment. So as I said, a recurring finding in the first two phases is the importance of adopting a holistic perspective on health. We also decided that we wanted to use case studies to get the group discussion started. With the use of these case studies, we offer the participants an opportunity to discuss different aspects of being a woman in war and displacement without them feeling that they need to share their own personal experiences, even if we, of course, welcome them to do so if they want to. And the case studies also gives us a chance to present that women's experiences of war and displacement are very alike, despite where in the world they come from. And through practicing body awareness, the women are given the opportunity to increase their self-awareness and hopefully feel more competent in making independent decisions regarding their health. And then we wanted the participants to have tailored psychosocial information relevant to them according to questions that may arise during the group discussions. And finally, we want to round up the group with a closing ceremony where the women have a chance to reflect on how it's been to participate in the group. And we also encourage the women to give us feedback on how to improve this intervention. And here on this slide, you can see the structure for the intervention. Because we meet during 9 sessions, each session being 2 hours long.
Specifically regarding the group intervention, we could see that the intervention has very much been appreciated, but we have seen difficulties attaining continuity in the group intervention. And most commonly, canceling the intervention has been due to somatic health reasons. The women that we see carry a lot of bodily issues that make it hard for them to come.
Yeah. And we saw that physical limitations also sometimes is a hinder for the body awareness training because the women are in so much pain. The group format was very much appreciated. The women liked to be in a group, they liked to share experiences together, and they said that it felt that they had support and it broadened their perspective on their own traumas. So we could say that the purpose of the intervention is fulfilled according to social support, and the participants shared their own experiences, but also could raise the discussions to a structural level. And the traumas was multiple and many around gender-based violence.
So at the end of both rounds of intervention, we asked the women what they thought about participating. And they said that they felt that it was a safe space to share thoughts and experiences. They felt seen and heard, and they appreciated getting the opportunity to meet with women who had similar life experiences and who were living in a similar living situation as themselves. One of the participants said, "It's important to talk to others who share the same experiences." What's in the future for the My Heart Sister project? We are now in the middle of the project's third phase. We recently started the first round of the MHS intervention for this semester, and our hope is to start another round in April. We continue to collect research data and will evaluate these and publish them when we have enough. In this coming semester, the plan is to start the work of formulating a treatment manual and also creating an implementation manual to facilitate spreading the intervention to other RKCs in Sweden. Our long-term aspiration is that the intervention will be available for women in the target group in other settings as well. We have also initiated a collaboration with the Center for Transcultural Psychiatry in Copenhagen with the aim of deepening our knowledge and sharing the insights we have gained from the project with other relevant contexts. We are excited and we're looking forward to the future with the project.